Thank you everybody for coming along to the Supporting Families with Cancer event and this particular talk about the use of tamoxifen as a preventative agent. The advantage of arranging a talk like this meant that I absolutely had to get the leaflet sorted out by today, so it's particularly useful for that. But also for our YouTube channel, because all the talks that we do go up onto our YouTube channel. At the moment, until my singing career takes off, you can put Julian Barwell in, and it comes straight up onto the channel, and there's nothing too embarrassing with my name in it otherwise. But we're here to talk about the steps that people can take to lower their risk of inherited breast cancer. And you may be aware that the National Institute of Clinical Excellence guidelines has been recently updated this year, and they've been represented by a number of different groups, including the National Hereditary Breast Cancer Helpline. I'm delighted that they're here in the audience as well. And one of the main leaders in this field is Professor Gareth Evans from Manchester, who's an absolute expert in this area, and he's helped us to develop this leaflet and was happy to endorse it. I'd also like to thank Exie Quinn here, who's a student from King's College in Peterborough, who's doing a project with us, and she's done a great job here. I'm helping with some of the developing some of the production values on the slide, so huge thank you to her as well. And obviously for Jo and all her hard work as well. So what we're going to talk about, try to make it fairly straightforward, is we've got 12 things I wanted to say today about tamoxifen and its role in preventing cancer. As I said in the earlier lecture, the risk of breast cancer for any woman who's in the UK today is 1 in 8. And I have to say that risk has really significantly increased since I started in medicine. We used to say 1 in 12. And now we say 1 in 8. Now, even people who've inherited a high-risk breast and ovarian cancer susceptibility gene, like BRCA1, if you were born before or after the Second World War, the risk of cancer has doubled, even in people who've got an inherited susceptibility. So there are lots of things that are probably involved, not just genetic factors, in affecting breast cancer risk. But the main risk factor that we tend to talk to people about is estrogen exposure, which is the female hormone. So, for instance, women that start their periods very early, have their menopause very late, go through lots of menstrual cycles, perhaps they've taken the combined oral contraceptive pill for a long time. These things are known to be risk factors for breast cancer. And what we know, obviously, is that there's multiple people affected with breast cancer in the family, then there's a risk to their relatives. One other point, of course, is that breast and ovarian cancer can be linked. So when we see breast and ovarian cancer in the same family, it really does sort of prick up our ears that maybe there is an underlying inherited alteration, perhaps in BRCA1 or BRCA2, and to watch out for that. What's important, if you're thinking about taking tamoxifen as a preventative agent, is to understand what your level of risk is and to talk to your genetics department about that. And on here, I don't expect anybody to read all of this today, but it is on the leaflet. It's a bit of a guide as to how to clarify your risk. There is a link, I believe, on the leaflet to the OPRA, which is the online personalised risk estimate of risk for breast cancer, which Macmillan have developed, which is fantastic, and we're working with Macmillan to try and develop one for bowel cancer as well. But basically, if you have 3 relatives in your family with breast cancer, particularly if across 2 generations with 150, you should be starting to think that there could well be a strong inherited component. But to give a flavour for what constitutes high risk, somebody who's got a 3 out of 10 risk or above, 30% or above, that would constitute high risk. As I said, background risk is 1 in 8, and moderate risk is approaching up to 30%. And these are the sorts of family histories that might constitute that. So moderate risk, 3 relatives diagnosed with an average age over 60, and high risk would be 3 relatives diagnosed with an average age under 60. One thing to watch out for are the hormonal negative breast cancers under the age of 50, because they may be related to BRCA1, and we offer a genetic test to anybody who has one of those types of breast cancer. So knowing your risk is absolutely crucial, because tamoxifen is only offered as a preventative agent for people who are either at high risk or at moderately increased risk. But remember, everyone's at a 1 in 8 risk, so that's pretty high even to start off with compared to other tumours. So what is tamoxifen? Well, tamoxifen is an agent which blocks the estrogen receptor in most tissues. It has a different impact in other parts of the body, but in breast tissue, it acts as a blocker to the hormone response in breast cells. So it's a bit like if you have a key which has normally has a lock. It's like putting some blue tack over that key, so it no longer can open the door. So the hormone can't act on the cell, so that the cell can continue to divide and to grow. And tamoxifen has been used for many years, as you're aware, in the treatment of breast cancer. It's very good at reducing the chance of the breast cancer coming back. But it's also been used in a number of studies over many years to actually show that it can reduce the risk of breast cancer. When it's offered, it will be offered for 5 years as a preventative agent. It's 10 milligrams to be taken once a day. It will be prescribed by the general practitioner, but if you're at high risk, you'll be asked to have a discussion about the benefits of taking tamoxifen by your geneticist, and if you're at moderate risk, that's possible that may take place in secondary care, and that means in a breast unit at your local hospital. What the tamoxifen does is that it reduces the risk of breast cancer by about 1/3, perhaps just over 1/3. So if somebody is at a 3 out of 10 risk, this means that if they take tamoxifen, then their risk of breast cancer goes down to about 2 out of 10. And we spend our whole time on Tuesday mornings going through fractions and mathematics with our counsellors as we discuss the risk-benefit analysis for patients. I'll let you off this time, thank you. Okay. But the tamoxifen has other benefits as well for health. So it also lowers cholesterol. It also reduces the risk of benign breast problems and breast pain. It also reduces the density of breast tissue, which makes mammograms actually a better test. One of the reasons why mammograms sometimes miss tumours in young women is the breast density is so great it's difficult to spot small tumours. And if the breast density is reduced with tamoxifen, actually it's better at detecting breast cancer. So these are the reasons why tamoxifen may be helpful. Now there are some side effects and some cautions for taking tamoxifen. I think the first thing to say is if you're thinking of starting a family, or you are certainly not excluding it, then please think very carefully about taking tamoxifen. And that's because it can affect fertility, and there are some concerns that it may affect pregnancy as well. So if you're thinking of becoming pregnant, or if you become pregnant on tamoxifen, it's very important that you tell your doctor and to stop it. The second thing is the time of when you might want to take it, and it's for people who are at high risk, they would take it for 5 years, and that could be possible from the age of 35, and if you're at moderate risk, you take it from the age of 40. And that's because of the risk of breast cancer associated at that ages, because the benefit is supposed to last for 20 years, so you take it for 5 and it helps protect you for 20 years. So I think it's safe to say that one of the concerns that people have had about taking tamoxifen is because they talk to women who have taken it as a response to breast cancer treatment, and they say, well, it causes hot flushes, night sweats, can it affect the mood, sleep disturbances, and there are been studies which certainly show that it does have some of these impacts. 14% more night sweats than people taking placebo, 29% more hot flushes. Often these symptoms settle down after a few months, and there isn't good evidence that it actually affects mood. It can affect voice and vision. There's a slightly increased risk of cataracts, and if you're a professional singer, then it's something that would be worth taking into consideration and speaking to your doctor before taking tamoxifen. The other two main issues with tamoxifen is the increased risk of blood clots. Hi, would you like to come and take a seat? You're very, very welcome to come and do so over here. So the risk of blood clots is doubled. Now remember, if somebody is at a 3 out of 10 risk of breast cancer. They take tamoxifen, the risk goes down to 2 out of 10. So that's 1 out of 10 people benefit from taking tamoxifen. The risk of blood clots, we're talking about 1 in over 100 people. So the idea being that for people who are moderate or high risk, that the benefits on the whole will be outweigh the risks, because the risk of the blood clot is obviously a lot lower than the likelihood of you benefiting from the tamoxifen. Obviously, because of the risk of blood clots, it's really important that you watch for other risk factors associated with blood clots. And the classic ones are smoking, periods of prolonged inactivity, such as if you're having an operation, or for instance if you break a leg, and something like that. Apart from seeing your occupational therapy colleagues, it would be good to also think very carefully about whether or not you should be taking tamoxifen. The other classical risk that is described is womb cancer or endometrial cancer. This is particularly a risk after the menopause, and that's why if people have gone through the menopause, we don't recommend generally tamoxifen. Raloxifene, which is a similar drug, should be offered instead. And they have similar side effects, but there's a lower risk of womb cancer associated with that. What can happen is that the taking tamoxifen can certainly lead to more endometrial womb gynecological investigations. But again, the absolute risk of gynecological cancer is much lower than the benefit of the likely benefit of taking the drug. I have to say, one of the questions we're asked about people who've actually inherited one of these very high-risk genes. So BRCA1, BRCA2, these genes are responsible for between 2 to 5% of all breast cancers, and about 1 in 200, 1 in 300 people carries an alteration in one of these genes. Now the risk of breast cancer, if you have a BRCA1 gene, is likely to be, for a woman, is approaching 50% by the age of 50, 70% by the age of 70, and 80% by the age of 80. And the risk of ovarian cancer is likely to be half of that. So these are very high-risk situations. And I have to say, for BRCA1 in particular, the tumours tend to be hormonal negative. So they don't tend to be estrogen receptor responsive. And as a result, for BRCA1 in particular, I don't think that tamoxifen is going to be helpful for BRCA1 gene carriers. BRCA2 gene carriers, it could well help, because again the risk of breast cancer can be very high with a lifetime risk between 70 and 80%. Tamoxifen could well be helpful. But remember, it only reduces the risk by 1/3. And so for a lot of BRCA2 gene carriers, they may wish to actually consider preventative surgery at some point. And that's something obviously that would be individual to that person considering taking that drug and their age. The age at which people would take these drugs, I think there's still some work to be done on that. Certainly, I think if you are high risk or very high risk, it might be something that could be possible up to the age of 60, for instance. So, in conclusion, the sort of people that might want to think about taking tamoxifen are people who've finished their family, people who are not considering preventative surgery, perhaps because we've not found a high-risk gene, although clearly there's a strong family history. And people who perhaps don't have a strong family history of blood clots in the family. And to date, not a huge number of women have come forward on wanting to take this drug. But I think perhaps as a few people start taking it and we start seeing how they go, perhaps more people will come forward. But this is, I think, the beginning of chemo prevention for breast cancer, and at the moment there's a talk at the same time about the same thing, curcumin for bowel cancer. So reduces the risk by 1/3, and I hope in time that we'll be able to develop a blood test that will go alongside that to look at breast cancer risk. And for those that went to our last event, Professor Jackie Shaw was talking about developing a test similar to if you've got, I don't know if anyone got the paper today, it talked about how statins have greatly reduced the risk of stroke. And when you take a statin, you have your cholesterol measured, and that's a biomarker of your risk. What we would like to be able to do is not only offer somebody tamoxifen to try and lower their risk, but to offer them a blood test that could help them see that their risk is going down. And I think that's going to be crucial. not just to be able to offer a drug to lower the risk, but to have that biomarker which says it's actually working. Because obviously a lot of women, they won't know if it's working, they only know if it doesn't work, if they develop a complication or cancer. Now I've got a whole series of other slides going in more detail, but I'll stop there to have the first questions that people may have. Please note that the camera is rolling, but we are very happy to stop at this point to make sure that if people don't want personal questions, then that will be not recorded forevermore on the web. So I'll be very happy to take any questions at this stage. Thank you. Hi.
Hello. I just wanted to ask if the reason why not many people have stepped forward so far is because they've read various different stories about the side effects and stuff, and it's just they want to see, you know, how other people deal with it first before they.
I think that's part of it. I think a lot of people have heard about blood clots and the womb cancer and the flushes, and they think, why would I do that when I might not benefit? So I think that's half of it. I think the other half is people who are very motivated to lower their risk often think about surgery. So I think it will actually, what people that will end up taking it will often be people that don't have a gene, who perhaps are in their early 40s. Maybe they've got quite a few children already, and they want to do something, but they're just not in the place where they're thinking about preventative surgery. It's not for them. I think it partly depends on your family history. I think for people who've lost their parents at a very young age to breast cancer, might feel very differently from somebody who had an aunt who was affected perhaps later on in life, and it didn't really impact on them to quite the same extent. So, but I think you're right. There hasn't been. I haven't had people camping outside my office yet asking to take the drug, to be honest. But I think it's partly because it's been slightly undersold with regards to the risk, the complications. But the cost-benefit analysis is that if your risk of breast cancer is high, even taking into consideration the complications, it's likely to benefit. But I think a lot of people aren't happy with taking a drug with side effects when it might not help them. So I think we've still got that issue. Hi.
Hi, Julian. Can I just ask about the description of the risks?
Yes.
And how that's identified. We talk about the terms of close relatives. What is meant by close relatives?
Yeah, that's quite complicated. Basically, if it's in a direct female line, so it would be mother, grandmother, perhaps aunt, that's relatively straightforward. And generally looking at first and second degree. So your first degree would be your mother, your sister, or your daughter. And second degree would be your aunts. Where it becomes complicated is when it goes through the paternal lines as well.
Right.
So, and this is where it often gets missed in primary care in particular, is that somebody might have two paternal aunts and a paternal grandmother affected, and the confusing message gets out that perhaps chaps don't develop breast cancer and therefore can't pass it on.
Right.
But these genes can be passed on through either line. Also, there are rarer tumours which can occasionally be linked, but aren't necessarily always associated with high-risk breast cancer genes. So there might be a pancreatic cancer in the family, or a melanoma in the family, that somebody's not quite clocked, might possibly be a subtle link. So what we say is we take a 3-generation history. So we try and take it the family history in all directions, because you never know what you might find. If you don't ask, you don't find.
Yes.
But for the ease of trying to work with this, generally it's parents, grandparents, aunts, first cousins. Hi.
Am I allowed to start taking it now that we know what's wrong with my legs?
Yeah, we'll have to talk in more detail about that, because obviously that's a more specific issue. the main, as I said, the main things is the risk to the womb and to blood clots. And the issue of blood clots is related to activity and blood flow. So I think that's a debate that we'll need to have. So the reason for these events is to get people talking, communicating, and I think what I will need to do is to communicate with your other medical providers to talk about more detail about them. So that's the thing. Everyone's individual, and I don't think it will be very easy to give for people just to receive a leaflet and to be told to get on with it. I think each case, everybody will need to look at all the factors in their family and their own health, because the first rule of medicine is to do no harm. So that's one of the reasons why people naturally are quite cautious with introducing these things. And I think a lot of the time people are really keen that somebody else goes first and see how they get on. But they want to go in the second wave. So maybe that's what we'll see over the next couple of years.
Sorry, how long does it take to actually start working with this disease?
I don't know the precise answer to that, but all I know is that if you take it for 5 years, it's likely to work for 20. So I would expect, given its estrogen blocking effects, it would work very quickly. But obviously, it partly depends on what your risk is at that age when you would take it. But somebody in their early 20s would be at very low risk getting cancer. Hi.
Are there would any males be taking tamoxifen as preventative?
I've not heard of men taking it in that context at the moment. It is occasionally used for men who have other tumours, and occasionally for men who have been diagnosed with breast cancer.
Yeah, I take it because I've had breast cancer.
Right.
But I'm thinking of if my son, I'm BRCA2.
Yeah.
So if my son was BRCA2, he wouldn't necessarily be...
Well, the risk of breast cancer...
It's quite small, isn't it?
Yeah, the risk of breast cancer, we always say, remember 7%, because the risk of breast cancer for men in BRCA2 is 7%, and 7% of men with breast cancer have got BRCA2. So you only have to remember one number.
Yeah.
But if you think about it, 7% is lower than the average woman's risk
Right.
in the general population, and it's 12.5%, which is 1 in 8. So, as it's not offered for women to prevent breast cancer because of the other risks which I've described, I very much doubt it will be offered to men. I think the issue for men with BRCA2 is going to be prostate cancer prevention and early detection. And we do know that green tea may be helpful to reduce the risk of prostate cancer. Processed tomatoes may be useful. And then we do have studies, and Becky's involved in that, and Sarah, looking at trying to detect prostate cancer at an early stage in men with BRCA2. But I don't see it being used as prevention. There was a lot of press about potentially prostate preventative surgery, but I think that was slightly misrepresented. And I'd be happy to talk to you afterwards about that if you want to hear more.
Can I just ask, are there the only 2 genes found, connected with breast and ovarian cancer so far?
No, there are lots of different genes that have been involved in breast cancer. There aren't so many linking breast and ovarian cancer, but we do think there are other breast and ovarian cancer susceptibility genes out there. Professor Naz Rahman from the Institute of Cancer Research is doing a project trying to develop tests for further breast cancer genes. I suspect next year there will be a test that will be introduced looking at more cancer genes. So at the moment we tend to test in small panels of 1, 2 or 3 or 4 genes. The Institute of Cancer Research with the Royal Marsden are introducing a 97 gene test looking at a whole series of different cancer genes. And as I said in the earlier lecture, for some families with unusual patterns, we're starting to look at all 20,000 genes. So I think things are changing. The 100,000 Genome Project, which is the government's introduced with big fanfare, is going to look at the whole genome. So not looking at all of the genes, but also at the intervening sequences as well. So I think there will be more genetic tests available. But to answer your question, BRCA1, BRCA2 does not explain all inherited breast and ovarian cancer, but a lot of it. If you don't have BRCA1, BRCA2 in the family, and there's breast and ovarian, it's a good start, but it's not conclusive.
So you're saying that you can have other related cancers that could be BRCA but not breast or ovarian in the
Yes,
family?
there
But how
may
would you
well be.
know, or would you never know if they were BRCA related or not?
Well, there are some conditions which you can examine for, or that you can get a clue from the family history, and we sometimes look for those. But what we tend to do here in Leicester is that if we have a family where we think there must be an inherited susceptibility but we can't find it, we track it. So I code it as 99999, which means that when these new genetic tests come along, I can then do a database pull on all the families where I think there must be a gene change. And I will then recontact those families and say, do you want us to have another go? We also have an email update service here with the supporting families with cancer. That's one of the things I didn't mention earlier on, is that if anybody wants to keep in touch, they can always call us, but if they can register an interest. So for instance, you might have a question about breast and ovarian cancer susceptibility genes. Some people may want updates on tamoxifen. How are people getting on with tamoxifen? You can register that, and then we will let you know when further information is published or available on that. We've got it's on the website. So put supporting families with cancer Leicester in. There's the email update service that we have. So all of our patients have the opportunity to keep in touch in that way. And we have lots of people who are keen to know when further breast cancer genetic tests will be available, because we've failed to make a diagnosis so far in their family, but we think that there might be something. So it's partly through us keeping a track of those families. It's partly by people keeping in touch with us via the email. But also when new genes are discovered, people do tend to recall us, and we're very welcome to receive calls from people if they want to talk again about new treatments or about new genetic testing or new screening. Hi.
If you went on tamoxifen and found side effects too much and came off it after, say, a year or so, what kind of protection would that give you? Is it proportional?
I do not know precisely. We do know that there are, if you take tamoxifen and you're struggling with side effects, there are sometimes other things that can be done to try and lower that. But the problem is you go on one drug, you end up then going on another one. To try and reduce night sweats, and a lot of the side effects settle down between 3 and 6 months. So we would urge people to try and stick with it through that time. But certainly I can get back to you as to studies on shorter term use. But we know for the problem with taking it short term is a bit like the same story with aspirin. We know that aspirin can reduce the risk of bowel cancer, but in the short term, the risks of bleeding actually outweigh the benefits. So if you're going to take aspirin regularly to reduce your risk of bowel cancer, you're really committing yourself to taking it in the longer term, because you only really see the benefit after you've taken it for at least 3 years. So because I suspect if you take tamoxifen, everyone's got these risks of the side effects. You're probably better off committing yourself longer term, because everyone in the short term is going to be exposed to the risks without having the 20-year benefit. But I'll ask Professor Evans if he has any experience of people who have come off it, and see if there's any prospective data on how many went on to develop breast cancer as a result. But we know that in breast cancer patients, it can up to half, when they've got a hormonal tumour, it can up to half the risk of it coming back. But the benefit seems to be mainly for people who take it for 3 to 5 years.
Do you, for preventative measures, is it a lower dose of tamoxifen than you would be taking if you were taking it like I am because I've actually had breast cancer?
I think it's the same dose, it's 10 milligrams once a day. often people who've had breast cancer, they change after 2 to 3 years over to an aromatase inhibitor, which works in a slightly different way. But this would only be with tamoxifen, pre-menopause, and raloxifene after the menopause if you've still got your womb, because of the lower risk of womb cancer.
And this is preventative, so
Yeah.
you'd have this other one as well for preventative.
Yes, you would, but you'd only take one.
Right.
So after the menopause, you'd either take tamoxifen or raloxifene. But you would take raloxifene if you've still got your womb.
And there's low doses and high doses of that one as well, is there?
I think it's just a standard single dose that is offered for prevention.
Okay.
But it's prescribed by GPs, but the discussion about the pros and cons would take place either in secondary care if you're moderate risk or high risk upward geneticist. Did you find it a big change hormonally when you went on tamoxifen?
No, not too bad at all. You know, I've had friends that said it was awful, but no, for me, I've had a bit of sweats, but not a lot, and that's it really. I'm fine. I think knowing that it's helping you is sort of outweighs the fact that you might have a night sweat.
Does anybody have any thoughts about what they've heard about tamoxifen in the community as a preventative measure? Or anybody feel that we're underselling it or overselling it?
What do you think is the right age to start on this preventative?
40 if you're moderate risk, and 35 if you're high risk, as long as you're not planning children. That would be the crucial thing.
And what would be the maximum age?
At the moment we're thinking 60, but that's something that we will need to look into further. The issues is that for certain conditions there's this concept of live-through risk. So if somebody is at, let's say, a lifetime risk of 80%, and if they've got to 65, then we don't say they've still got 80% risk of breast cancer. We say their risk is much lower. And obviously the risks of tamoxifen are there if you take it when you're 90 or if you take it when you're 40. So it's getting that cost benefit right. And I think it would depend on the gene and the situation. For moderate risk, it's only going to be generally recommended during 40 to 50. And my understanding for high risk, it will be 35, potentially up to 60. But whether or not people who carry BRCA2, it will be beyond that, I think it still needs to be slightly teased out. Because you've got to look at the breast cancer risk, you've got to look at the breast density, and you've got to look at also obviously how old somebody is and the likelihood that they'll get that 20 years of benefit. I think it also depends on the patient and how they feel about the risk. That's by far the most important thing. I didn't know if the National Hereditary Breast Cancer Helpline would like to say anything about the experience they've had. Because they must have had people ask about tamoxifen.
Yeah, I think sometimes in the media it's misportrayed, and it's been given sort of the idea that it could be a miracle drug, and I think it completely wipes out your risk, which, as Julian said, it only drops it by a third. So someone who would want to have all their risk, or as much risk as possible, to be taken away, discuss surgery with us normally and go through that process of making their own choice, because it's certainly not for everybody, and it is a very long, difficult decision to come to for some people. And we're just there to give the information that we have and give support from various different people who have been through the process and made lots and lots of different choices on surgery, not surgery, screening, the ovarian and the breast surgery. So don't think to come to us, you've made your decision on surgery, it's your own choice, and we will help you come to your own choice rather than our choices.
Am I not right in saying that you can only have surgery if you've got for to BRCA1 or 2?
We do have some patients who go for surgery who don't have the gene because they have a very strong family history. In the past, we were only able to offer testing on people who were alive and affected. But that's changed recently as well, where we can now offer a genetic test to somebody who's unaffected if there's nobody else alive in the family to test. But even still, even if we don't find a gene, if somebody's risk is felt to be still very high, then they are potentially eligible for surgery. To put it into context, when we think of somebody being very high risk, we're talking about over 1% per year risk. So that's the sort of the gateway percentage risk. If your risk is over 1% per year, then preventative surgery becomes something that's considered. But obviously it's a big step to take. So when people are thinking going down that route, we offer them the opportunity to get in touch with support groups like National Hereditary Breast Cancer Helpline, and also to go and see clinical psychology and to talk about it with the breast team.
But does National Health do that? Because when I spoke to my consultant and yourself about having second breast removed as a preventative, both of you implied that National Health wouldn't.
Yeah, for people, the situation is slightly different for people who've had breast cancer. We know that if you've got the BRCA1 or BRCA2 gene, the risk of breast cancer is twice as high on the other side than if you don't. So in that scenario, often surgeons will only operate if there is the gene. And that's because below, if you don't have the gene, you're generally below that threshold. It's 7.5% 10-year risk. And if you've got the gene, it's 15% 10-year risk. And that's situated, and again, related to the cost-benefit analysis, somebody who's had breast cancer, the odds ratio is slightly different than somebody who's never had breast cancer. So there's different mathematics involved in that. But it depends again on the family history. We've got the odd 1 or 2 patients in that scenario who have gone ahead with further contralateral mastectomy. But I have to say it's rare. The vast majority of patients who've had breast cancer, who don't have BRCA1 and BRCA2, don't have a second mastectomy. Well, we're getting more requests in the last few months. The 2 main types of people who have come forward since Angelina Jolie are people who have always known there's a family history, but it's tipped them over to, yeah, I want to talk about preventative surgery. And the other group are newly diagnosed people who are diagnosed with breast cancer and say, if I've got BRCA1, BRCA2, I want double mastectomy. So it's had a double impact. But breast surgeons will not, very, very reluctant to remove normal breast tissue. And at the moment, they tend to use BRCA testing in people who have had breast cancer as a guide as to whether or not they will do that. Anybody else got any questions they'd like to ask about tamoxifen? Well, thank you very much. That's the end of the talk. Anybody who'd be happy to be a patient rep who's either taken tamoxifen or would like to be able to talk to other patients about tamoxifen as a preventative agent, they'd be delighted to, if they'd like to talk to us about that, because we're always looking for people who are happy to share their experiences with patients. That would be fantastic. Thank you very much.